everyone. Thank you so much for joining us. Another episode of Stories of Care, the podcast that explores the interconnection between healthcare equity and infection prevention and control. Today, we have got a great group of lineup to discuss a special program at the University of Connecticut School of Medicine. So we have three different people who've all been through the walks of life at UConn. We have Catriona, a medical student, Dr. Baldwin, an internal medicine physician, as well as Dr. Banach, who's an infectious disease physician, to tell us what they are doing at UConn. So to kick us off, let's hear about what each of them have done and what their stories are to get them to where they are today. Catriona, let's start with you.
Hi, nice to meet you. My name is Catriona. I'm a third-year medical student at the University of Connecticut. I'm also part of the AMA CDC Project First Line Faculty Work Group. And I've been working on some quality improvement in infection prevention and control projects at UConn, in part facilitated by Dr. Baldwin.
Hi, everybody. I'm Dr. Jennifer Baldwin. I'm a hospitalist director at University of Connecticut School of Medicine. I also teach patient safety and quality improvement to our medical students throughout the continuum, as well as to our trainees, so our internal medicine residents, during their intern year.
So hi, I'm David Banach. I'm an infectious disease doctor here at UConn. And I'm also the medical director for our infection prevention program and our antibiotic stewardship program. And I, in addition to my role in patient care, I'm also involved with mentoring trainees, so medical students and residents who are interested in the field of infectious disease and more specifically infection prevention and antibiotic stewardship.
Well, thank you three for all being here to discuss what's going on in your work today. And the thread that's apparent in all of your introductions is you all work in that intersection with quality improvement. So can you tell me, what exactly is quality improvement? What do we define it as in medicine?
So I can start. So, we work in a really complex environment of care where we have medical knowledge, research that tells us what we have to do, but very often our systems do not allow us to execute and operationalize what's intended. So my goal with trainees and medical students is to really have them understand this concept in the beginning of training, something that when I was training, we didn't talk too much about, and that they can understand how system and communication and different things come into play when we're trying to really provide high quality evidence-based care to every patient we touch.
So how do you embed that early on as a trainee? You're talking about a special curriculum. Can you tell us a little bit more about this?
Yeah, so what we are doing at the University of Connecticut is within the first year of their training, we actually introduce the concept of patient safety and quality improvement through having a patient come in and share her experience and at least leveling the playing field. And so our students at that stage have not seen patients, although we do have our students go a half day a week from the very beginning of medical school to an outpatient ambulatory setting, which is wonderful. But just learning that things can go wrong and how to have an eye for it and how to really set up a culture of safety where it's not with blame for the people that maybe have done something, but how do we look at it to make ourselves better and really, again, deliver high quality care 100% of the time.
And Catriona, from a medical student perspective, what was your view of quality improvement or QI before you started this curriculum?
Absolutely. So I think as a medical student, I had very little exposure to QI prior to coming to medical school. There's this direct connection to patients and patient safety. So we're able to see sort of through clinical practice and experience how different parts of the healthcare system can tie into sort of directly impacting patient care. So it was an interesting, new outlook on medicine and research.
Mm-hmm. And so you started this exploration in your M1 year, this initial experience. What was your perspective of that experience?
Yeah, so I think that it opened a new perspective. I actually became interested in quality improvement after there was a lecture by one of the infectious disease physicians who's very involved in our medical education as well. And I had previously been interested in epidemiology, particularly hand washing research. So I approached him after the lecture and he was able to connect me to the UConn's epidemiology department, which is how I got involved in QI research here.
That's awesome. And Dr. Baldwin, is that pretty typical that you see students after that M1 experience in your curriculum just really run with it and start reaching out based on what they've seen? Or do you have more formal ties in your curriculum to help facilitate that?
Yeah, so after the M1 year, the goal is to thread it through the 4 years of training. So we meet them right before they start their clinical in the M3 year, although it's really starts in April, so it's a little bit earlier. And we meet again to just remind them that now you're going to go out into all these different environments of care, and to remember you're going to see things, and we want to talk about reporting and having innovative ways to make it better. And then I meet them also during their internal medicine rotation. So I have smaller groups sit down together to just really debrief and reflect on things they have seen. Was it reported, and how did it affect you, and what do you think could be done differently? So those are really informative, and I think a nice way to just allow the students some free space to talk anonymously just about patients and different care environments. And then we have something called Home Week at UConn, where all the students come back from their clinical rotations and do a number of different educational activities. So I meet them again, and we actually do a simulated analysis of a patient safety event, where we sit in small groups with faculty mentors. Dr. Banach is one that joins me because we need a bunch. And we talk through how to really analyze an event. And then I send them out to find an event and to take a stab at it. So knowing that they're not going to be experts in this analyses of a safety event, but how do they look at the things that they're seeing and at least put it together? And then we come back again during Home Week at the end of their 3rd year, and they actually, I pick maybe 15 of them, and they sit in small groups and really dissect the event that they saw. And the goal is to take, because I think it's really important when it's a face of a patient and something happened while they were trying to provide care and they got to know someone, and something maybe didn't go exactly how planned. And so how do you then take that event, analyze it, make it better, but use those changes or interventions to drive quality improvement? So that's where you're thinking about, all right, what is the problem? What is an aim? And what can we measure? And how do we make sure that if we make a change based on this event, we're actually studying that and lending it to quality improvement work? And so I do see students, your initial question was do they take it from there? And so some of them do go on to actually do these projects. I might find that quality improvement work is a little simpler to do during medical school than maybe a longitudinal research project, just because you can do the rapid PDSA cycles and really see things change in the time you have.
So it's really about setting up the framework for people to carry these principles through into the future.
Correct.
That is really great. Dr. Banach, you've been a facilitator with this. Now, what is your perspective of how this has morphed over time, and your interactions really with the students as they're going through this process?
So I think it's been terrific. I've been working now with Dr. Baldwin as a faculty facilitator for the last few years. And, I think that it really opens the students' eyes to the concept that, they're part of a healthcare system, and healthcare delivery is complicated. I think the traditional thinking is that it's, a physician-patient interaction, or a student-patient interaction. But, I think that introducing this early helps students understand that they're part of a larger framework of healthcare delivery, and that there's opportunities for improvement in a lot of different areas. And I think that it's something that the students really do carry with them throughout the 4 years of medical school, and hopefully beyond, as they start to look at things that are occurring in clinical settings, and that they identify opportunities for improving practice.
And it seems that in the world of QI, a lot of this ends up intersecting with infectious disease work. What has been your experience seeing that as far as a project perspective?
Sure. So I think that, this starts early. So in the curriculum that Dr. Baldwin is describing, students often identify problems that are related to infection prevention and control. So these are, there's certainly several different areas where students identify practice gaps, but, infectious disease and infection prevention and control are two that frequently get identified. And I think that's the first step, for students to identify where there's opportunity for improvement. And then some students really do become quite engaged with it and build off their own projects in these areas, and identify opportunities that they can really dive into and do some further studies and further assessment, and then these can morph into like full projects. So all of our students here at UConn are required to do a capstone project by the time they graduate medical school. And I've worked with a few students that have done these projects in the area of infection prevention and antibiotic stewardship, and based off their own clinical experiences. And I think that introducing this early on in the first and second year of the curriculum helps students identify their own personal experiences in infection prevention and infection control, and identify opportunities to explore those further if they're interested.
Why is it, do you think, that so many of the projects that are identified end up being infectious disease related?
I think, infection prevention is such a huge priority in healthcare. We know that we have infections that unfortunately do occur among our patients in healthcare. And we know that, antibiotic prescribing is maybe suboptimal in a lot of different areas. So, and I think the students do identify this relatively early on. And they recognize that there's opportunities to improve. I think, the first time that you take care of a patient who develops a healthcare associated infection, it really does occur to you that, there's opportunities here that, looking back, maybe we could have prevented this from happening. These are events that really shouldn't be occurring. And I think the more we dive into them, the more we identify opportunities that they can be prevented.
So what are some of the projects that you've worked on? You alluded to the capstone project.
Yeah, so I've had the opportunity to work with several medical students in different areas, they've ranged from and they've really generated from things that they've seen in their own experiences. So, I have students who approached me who saw a patient who had a C. difficile infection, and that was traced back to some antibiotics they had received during dental care. And the student became interested in understanding, what is the prescribing practices in dental care, and can that potentially lead to C. diff, and what are there opportunities to improve prescribing in dental care. That was her project. I had another student who was interested in antibiotic prescribing in the setting of viral illnesses, and what can we do to try to reduce unnecessary prescribing when viral infections are identified. And built a project on working with our emergency department in using diagnostic testing and sort of an algorithm to try to reduce unnecessary antibacterial prescribing in the setting of a suspected viral illness. So, I think a lot of these projects really stem from the students' own experiences. And by really, thinking about these early on during the first and second year through the quality improvement in patient safety curriculum, students start to recognize those experiences that they can sort of build upon with projects later on in medical school career.
With so many of these projects, it sounds like there's a direct implementation that's possible in the UConn itself. Have you seen that happen and be sustained after the results have come through?
So, yeah, I think the students do have the opportunity to really engage in these projects and make noticeable changes. One idea that comes to mind is we had a student who was interested in understanding the urine culturing practices and when they may or may not be indicated. And she actually sort of built a sort of order that helped with reducing unnecessary antibiotic or urine culturing. And that's something that we've kind of begun to implement here, based on her work and her identifying these opportunities for improvement. So, the students often kind of plant the seed either through the data they collect in their projects, and then identifying and sort of understanding the problem. And then we can build upon that sometimes while they're still students, but often after they graduate, in actually implementing some changes.
And Catriona, from your perspective, you are talking about this hand washing project. Is this going to be your capstone project? And what do you hope to glean from it?
Absolutely. So initially I was thinking about making this my capstone project, but I ended up taking my interest in a different direction for that specific project requirement. But with the hand washing research, I think that it was a really interesting and informative learning experience in that I got to understand the hospital system a little bit more fully. So not only is this a quality improvement IPC related project, I met with the epidemiology team. I learned why they need to do this hand washing reporting, why having good compliance is so important. And I started to understand a little bit more about quality metrics, accreditation, the role of the nursing teams on each unit, how important it is to involve different departments and different stakeholders in implementing a project. Because if you sort of try to go right in and make a change without understanding all the different components and sort of how things are done, the project will fail. So I think it was more of a very good learning experience for me than necessarily resulting in any systematic change in the hospital. What we did see, so we implemented a new reporting system via Google Forms versus a form that would only be accessible to people who registered. And we opened it up to other staff in the hospital, so like chaplains, technicians, sanitation workers, et cetera. And what we saw is that other staff are interested in participating in these like infection prevention reporting behaviors if given the opportunity. So that was an interesting outcome. So I think I more so gleaned information about, yes, just like the hospital as a whole, which is really helpful like moving forward, because in residency I will be doing quality improvement research. So it was a very good building block.
Have you thought about applying those results that you discovered with other staff involvement at UConn itself?
Absolutely. Yes. So I spoke a little bit. So one of my mentors is actually the CMO of the hospital. So I've had some informal mentorship from him in the clinic, which has been really helpful. So we've discussed the results and then potential future implications of this research. I think the nice thing about quality improvement projects is that they can be smaller scale. So you can start a project and then pause it for a period of time where you think about it, discuss future options for it. So I'll be revisiting it again soon and sort of figuring out what the next steps for it will be. But I do think there are some large implications. It's just starting at the root reporting system versus trying to implement something sort of too quickly, which is, I think, what happened with this project.
No, it sounds like a very interesting project and something that we could definitely learn how to improve IPC care. Dr. Baldwin, this curriculum just seems very unique. Are there any other schools that are using this type of QI approach early on in training?
I'm not sure, not that I know of, that bring it in. So we were, in terms of patient safety training, we were one of 7 institutions chosen by the ACGME to introduce patient safety concepts with interns in 2017. So UConn being one of them. So coming up with innovative ideas, how to get everyone involved early on. And I do really, even listening to Catriona talk about things, it's really nice because you can kind of understand the framework of QI, but you really have to get your hands dirty and do it to realize some of the things she's learned. Like you could put down something on paper, but getting the stakeholders, understanding the complexities of our systems, understanding all the different layers of who's involved, matters so much. And if you don't have support and people aren't bought in, they're not going to do your little action plans and your changes that you implement. So, I went a little out of your question, but I think it is so important for them to just understand from the beginning, whether it's medical school. And then obviously a lot of our interns that come in have not had the training that our medical students have had. So I don't know exactly if other schools are doing anything like this, but not at this scale, I don't believe.
So say from all 3 of you, it's very clear that there is so much foundational skills that can be learned through such a curriculum and that it really just benefits the system overall. If somebody wanted to apply this curriculum to their own school, how would you suggest that they start implementing something?
So you have to have people that are engaged and involved and are really passionate about this work. So I think my administrative role as the director of hospital medicine here at UConn, I just see firsthand how we have to be better all the time. So I think in order to come across to the students that this matters just as much as the Krebs cycle and all the other things in year 1 that they're learning, that may not be the majority of their STEP exam, but how do you get them engaged? You just have to have faculty that are passionate and are going to work with you and really know the hands-on clinical work that has to be done.
How long did it really get you? I mean, I know that you started looking at this with ACGME in 2017, from what you were saying. How long before you really got to the point where you're at now, where you just have this very integrated, stepwise way of teaching these skills throughout all 4 years?
It evolved over the last 5 years, I would say. So it started by we actually had our students doing quality improvement projects within ambulatory medicine. So it was a 6-week rotation, and they would do a longitudinal project at each internal medicine site, and they would hand it off from group to group. And they would present it at this Dean Symposium on quality improvement that I discussed, but it varied the mentorship they got at all the various ambulatory sites. And some students were very engaged and some were less. So UConn's curriculum changed in that the ambulatory rotation in IM went to 4 weeks, and they felt it would be really hard for the students to be engaged in QI in that short amount of time. So they asked if the students can join the internal medicine resident programs projects. I was the associate program director for our residency at that time. And I said, inpatient projects, sure. But then we had these big groups trying to integrate, and it was, again, variable engagement. And that kind of then evolved into, all right, how do we get them involved in the symposium if they're not doing their own projects? And we came up with, well, they can assess the projects of the residents with a mentor, and we can teach them the skills, and maybe have them come up with a theoretical project. And then it was about the time where we were introducing this with our interns with the ACGME, and how do we incorporate patient safety? So my kind of thought was, in order to understand systems, maybe we break it down to the patient level, because they are getting out there, seeing patients. You're going to remember that patient, take an event that happened, and then turn that into understanding more longitudinal QI work.
Mm-hmm. And Dr. Banach, it sounds like mentorship is so critical to the work that this curriculum involves. You've mentored several students to the projects you were discussing. What is it that you see yourself being able to do as a mentor to help students succeed and learn these skills?
So, I think that the mentorship role is something that I've personally enjoyed, and a lot of my colleagues do as well. And I think that, we have a lot of faculty that are very much invested in quality improvement and patient safety efforts. And a lot of that is stemming from our own institutional leadership culture that's highly invested in patient safety, starting at the C-suite level. And I think, just to go back to Dr. Baldwin's point, I think that having institutional leadership investment in this type of program is really critical. I think both within the healthcare system, but also within the medical school leadership. So I think that's really, for anyone who's starting this out, I think getting buy-in from leadership is really important. And then as far as the mentorship,
I should just point out that Dr. Allen, who was mentioned, our chief medical officer, developed the curriculum with me several years ago. So we really have, and he still is involved in the education. So it is coming from the top down. And that's who Catriona was referring to as her mentor, is the CMO of the hospital. So sorry to interrupt.
That's so critical.
Yeah.
But I was just going to say that I think the mentorship role is something that I've enjoyed, but also have found it to be quite fruitful. And being able to identify these gaps, and not just in infection prevention and control, but other areas of patient safety as well. I think the students identify opportunities for us to understand where we have places where we can improve. And the students, like our house staff, are really at the front line of healthcare delivery, and they see gaps that some of the faculty or the attendings may not necessarily recognize. I think being able to have that communication and then eventually seeing them to quality improvement projects and improved patient care processes, I think is really something I find satisfying. I think the other faculty mentors do as well. So, I think we really tap into the students both for their inquisitiveness as well as their kind of unique roles in healthcare delivery and their ability to identify opportunities for improvement and act on them.
How many years have you been involved as a mentor and a facilitator?
Geez, I think at least the last 5 years, I've had opportunities to be part of the curriculum. I've seen it grow. I think it's been, Dr. Baldwin's really done a terrific job in ushering this through and, expanding on it and really making it a robust experience for the students, but also for the faculty mentors.
And so having at least seen a few groups of students go from being M1s all the way through graduation with this curriculum. What have you noted in their growth throughout that period of time?
I think it really raises awareness to the students of their roles, but in healthcare delivery, and also the sort of challenges and complexities of healthcare delivery. I think when you look at a single opportunity, or I don't say a problem, but so maybe a care gap, and start to really dive into it, you really start to understand how complicated healthcare delivery is. And I think that's really an important lesson for students, and being able to introduce that early on during the first and second year curriculum, really enriches the students' awareness as to what they're engaged in during third and fourth year, and hopefully beyond, as they become, residents and, eventually attending physicians. So I think that, our students are very aware of their surroundings, the complexities of healthcare, and I think that helps make them better doctors.
Catriona, being one of those students, I would love to know what has been your favorite experience or the most valuable thing that you think you're going to take away from having had this exposure?
Yeah, that's a really good question. I think there's a couple different things. So one, the QI curriculum has helped me just be able to identify potential projects and gaps in patient care, which is something that I think you need to do through like practice and experience. So for example, I'm starting a new project with one of my classmates on how to increase quality metrics in the chart using a template. So including like lines, drains, antibiotic prescribing, et cetera, which is something that we noticed rotating at different sites. There was different ways to incorporate that into notes. So we're trying a new system to work with residents to do that at UConn. So just being able to identify issues, as Dr. Baldwin and Dr. Banach mentioned, is a really important skill that I'll take forward into residency. And then also just finding really incredible mentors throughout the process. I think that is one of the most important, valuable things I've taken away from this, is how to find mentors and then cultivating those relationships and finding new opportunities through them.
That's really great to hear, that this is the type of things that you look forward to applying in the future, that it's not just a lesson for today, it's something that can be ubiquitously applied. So I want to thank all of you for being here today. But before we go, I want each of you to tell me one thing that you want to leave our audience with. From this discussion, from your experiences, what is the one thing you want somebody who's listening to this podcast to walk away knowing? Let's start with you, Catriona.
Sure. So from a medical student perspective, I think that the most important thing for individuals trying to increase QI or IPC medical student involvement at their institutions would be increasing exposure. So having physicians present on their research, on their infection prevention projects, and then connecting them with residents and other resources is a really great way to facilitate involvement.
And Dr. Banach, what is the one thing you want to take away?
So I think from the faculty attending perspective, listen to your students. They are very inquisitive, and they can give a very unique perspective in identifying opportunities or practice gaps. Students may pick up on things that we may not necessarily be thinking about, because we're so kind of ingrained in healthcare delivery and the culture. And then students bring a new perspective, like a fresh set of eyes onto a system, and they can really identify opportunities. So listen to your students when they bring up ideas, encourage them to share their ideas and their observations with you, because I think they really do provide a great opportunity to improve patient care.
Great. And Dr. Baldwin is one of the masterminds behind this curriculum. Same question to you.
Yeah, I think it is really important to give the students a platform early on to understand that medicine is not just about what we learn in the book or even one-on-one with the patient, but there are all these complex systems at play, and we have to give them the space to understand that things can go wrong and that it is okay to reflect on it, talk about it, as long as we're doing it to try to make things better and to grow as a system and as a healthcare organization.
Stories of Care is a publication of the AMA and CDC's Project First Line. Project First Line is a national infection control training collaborative working to provide all healthcare professionals with the foundational infection control knowledge they need and deserve to protect themselves, their patients, their coworkers, and their communities. For more information, trainings, and other infection control resources, visit cdc.gov/projectfirstline and amafirstline.org.